Thank you very much to our panel here and to our directors for the opportunity to present today. I have no disclosures. So what is healthcare transition? It's the process of getting ready for healthcare as an adult. And the goals are to improve the ability of youth and young adults to manage their own healthcare and effectively use health services. In 2002, a joint recommendation was made by the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Physicians describing a framework for a smooth transition to adult health care for adults with special health care needs. And the goal of this is to maximize lifelong functioning and well-being for all youth. Transitional care should be a very purposeful, planned process that addresses the medical, psychosocial, educational, vocational needs of adolescents and young adults with chronic physical and medical conditions as they move from a child-centered to adult-oriented healthcare system. And adoption of transitional programs and application of these principles are very limited, unfortunately, especially in pediatric surgery. And we know that an unsuccessful surgical transition may have high consequences, resulting in physical and mental health implications for young patients, negative long-term outcomes, and suboptimal use of healthcare resources. 25% of IBD cases are diagnosed during childhood, and we know that child-onset IBD is much more severe than adult-onset IBD. There's a more severe phenotype, a more extensive disease location, increased use of immunomodulator therapy, and higher risk of malignancy. Children with IBD have a threefold increase in risk of death when followed through adulthood compared to the general population. And this is due to liver failure, cancer, infections, and respiratory diseases. IBD patients that are found to be at increased risk for poor health outcomes at transition are the ones that are diagnosed with mental health history, ones who have a history of noncompliance, and those that have active disease. And so these patients in particular really need a really good transition program so we can prevent their flares and decrease their loss of follow-up. Our group recently looked at what are some of these barriers. Why can't we transition patients well? We looked at this in anal rectal malformation patients, but I think it does apply to IBD as well. We had 38% of pediatric surgeons complete the survey. It was a survey done by both pediatric and adult surgeons. 17% of those pediatric surgeons said they had a formal transition program, but only 7 of that 17 regularly assessed for the readiness to transition. Only 26% had a formalized education to transitioning those patients, and 77% had identified adult providers to transition their patients. However, on the adult side, as you can imagine, it was not as participatory. Unfortunately, we only had 2.8% of adult colorectal surgeons who completed the survey. Of that small percentage, only 17% said they participated in a formal transition program, and only 2 used a formal transition summary packet with a formalized post-transition follow-up. What we identified from both pediatric and adult surgeons was that the main barrier was that there was no structured transition program at their institution. On the pediatric side, they further identified a lack of multidisciplinary team approach for those complex patients on the adult side, and a strong parent and patient attachment to the pediatric team. The adult side further identified a lack of understanding of this complex post-surgical anatomy, and it was hard for them to identify adult surgeons within a reasonable geographic location for the patient. So what does healthcare transition look like? This is the generalized timeline that's used, starting at age 12 into the 20s. The process should start around age 12 to 14, and a general health knowledge tool should be used to assess the patient's understanding with an annual readiness to transition worksheet. It should be completed both by the patient and the parent. You need to identify an adult surgical provider to pass them off to, as well as once the adult provider has them in their clinic, they should complete a documentation of transfer completion. So how do we do this at our institution? What is our model? Well, we have at Nationwide Children's Hospital and at Ohio State a very specific model. We have our first discussions at Nationwide whenever the first the first appointment with that patient, whether it's an infant or it's an adolescent or a young adult, we let them know that we have a plan for them, that when they have a new diagnosis of anorectal malformation in the NICU, they don't have to be worrying about what's going to happen to my child as an adult, because these are questions they do ask. It's not a full conversation, but it's just a sentence. We have a plan. We'll talk about it later. However, when they do get to be 12 years old, all of our patients have an annual readiness to transition survey that they receive every year, as do their parent. And we have a multidisciplinary approach where we're involving urology, gynecology, GI, social work, and psychiatry. We also let them know that we have this same multidisciplinary approach for them waiting on the adult side. So at 12 years old, they get this survey, and the social workers and the providers go over that survey with them. The survey really focuses on the key facts as far as how important is transition to them? How confident do they feel about transition? And this is something we assess every year. We also ask them, what about their health? How much do they know about their diagnosis, and how do they know how to take care of themselves? Do they use healthcare effectively? And we work with them. Who can help them with this? Identify someone who can help them if they need to work on that. So the social worker and the providers evaluate the survey and decide if the patient is ready for transition. The factors that indicate readiness are when the patient can describe their medical needs, speak with the providers themselves. We've all seen those young patients who are on their phone during the whole clinic visit. They're not answering any of the questions. The parents are stepping in, answering everything. We really need to focus on having the patient be ready to be an advocate for themselves and to be able to answer the questions themselves, know what the scars on their belly mean, and be able to fill out the paperwork and schedule their own appointments. So when we've identified that a patient is ready, they meet with me, the adult provider, in the pediatric setting to discuss the transition unless they're already my patient. And then the patient schedules their follow-up appointment themselves with me at OSU. When a patient is not ready, however, we work with them to set goals and facilitate referrals to different support systems to help them achieve that goal. And this is why it starts at age 12. It's a gradual, slow process. We also recommend individual tasks throughout their year until they see us next time that they can work on, so that next year they're ready, they've checked that box, and then they can move on to other areas of their healthcare transition where they may not feel as comfortable. We recently looked at our process of transitioning, and this will be published in JPS in August. And we wanted to see how were we doing. So we had 41 patients between June and July of 2023 with a median age of 15. We had 23 females and 18 males. The majority of the patients had the diagnosis of anorectal malformation, followed by functional constipation, Hirschsprung's, and other, including IBD and myelomeningocele. We had 23 patients, 56%, who were referred to adult practice. We found that there were no differences in gender, developmental delay, or diagnosis, and the factors associated with referral were that they were older, of course, 17 versus 14. These patients also performed healthcare tasks autonomously, and they were more confident about transition. We saw that there were patients who had not referred to adult practice, had room for improvements. 35% felt that they could not perform healthcare tasks independently, but were still able to be referred to adult practice. Some of the things that patients want to remain in the pediatric setting are very understandable. They may just be more comfortable in the pediatric setting. They're used to it. They may see other providers in the pediatric setting, and it's just more convenient. Or they may have out-of-state insurance, which is sometimes a barrier. Other perceived challenges are there's medical trauma associated with having a chronic medical illness. They may not be interested in transitioning, and they may not be exercising independence in an age-appropriate manner. And there are some patients who have disabilities that prevent them from managing their own care. They may never get there because of their congenital disease that they have or their disability. So we do facilitate with the family that governance and transitioning what medical legal documentation they need to have at age 18. But we do also offer possible solutions, like connecting with psychology and a community disability agency and setting realistic boundaries and expectations with both the parent and the patient. There are additional transitional concerns that we'll talk about a little bit later in the panel as well, but discussing reproductive potential, that can be dependent on anatomy, and they may need an alternative method to create a family. We'd also encourage preconception counseling with high-risk OB, having copies of the operative notes for the OB to have available, and evaluation of concurrent medical conditions like renal insufficiency. And we always like to discuss recommended modes of delivery, particularly for our J-pouch patients, vaginal versus C-section, and other urologic and colorectal considerations. There are also these emotional and cognitive concerns that you have to consider with the transitional care. Information needs to be provided in small increments over a long period of time. Talking about transition once is never enough. It's not like the patient reaches 18 and they're done, you close the door. This is why we start at age 12, and this is why I also say that transition is a process, not an event. It's a loss of relationship, guardianship changes, and release of information. All these things that the patients and the families are getting used to. Tips I have for transitioning to adult care include teaching your patient about the following topics: all aspects of their disease and associated medications, the importance of adherence to medical recommendations, and how can they advocate for themselves. In conclusion, by using a standardized protocol, patients can be identified for transition of care. Those who transition care are most likely to perform tasks independently and feel confident about their transition of care, and further work is necessary to identify outcomes and experience with transition. And that's our next project. These are some great resources, gottransition.org, and thank you for your attention.